Onc Live Insights is a video editorial program produced by Onc Live.
Unfortunately, despite the improvements we've made either with targeted therapy and chemotherapy, all patients will eventually progress. And that's when we talk about second-line therapy. Patients who have the greatest benefit from second-line therapy have good performance status and have had a response to chemotherapy before. Generally, for those patients, if they've had long disease control, for example, with pemetrexed maintenance, they have minor progression, we'll talk about enrollment on clinical trials or switching therapy, changing to second-line therapy with either gemcitabine, which is not FDA approved, or docetaxel, which would be conventional. I am less likely to use erlotinib in patients who have wild-type disease and have good performance status if I feel like I can safely get in second-line therapy. We know that these drugs improve overall survival and control symptoms. Generally, once I start second-line therapy, my aim with a drug like docetaxel is to get in between 4 and 6 cycles. Often the toxicity may prove too much. Sometimes I'm surprised and patients tolerate it quite well, and we see consistent responses. I think where it becomes more difficult is in patients who have either had a fair bit of toxicity from frontline treatment, who are refractory to frontline treatment, or who have multiple medical comorbidities. For these patients, the idea or the goals of second-line therapy, I think, need to be explicitly stated. So for patients who have not had good disease control or who are refractory after 2 cycles of carboplatin or a platinum-based doublet, the likelihood that we'll have significant disease responses is difficult or is much less. And for those patients, we talk about response rates that are in the order of about 10% in the second-line setting. Certainly for patients in whom there may be a driver mutation that we haven't found during the frontline setting, such as EGFR or ALK, if we find they may have a BRAF mutation or a RET translocation, we really try to push those patients to clinical trials. And often we're finding those after initial chemotherapy has been initiated. So for those patients, we would expect a pretty significant response. I generally tell patients and counsel my families that we have a plethora of drugs in 2014. The best regimen for that patient depends on how well they're feeling. And so at any time, I tell patients to be as active as they can, to do everything they can to support their general wellness, because it's very likely that we can give a second or third line regimen that would likely improve their outcomes. For patients who have a lot of symptoms from progressive cancer or a lot of toxicity from previous therapy and are really performance status 2 or 3, the benefit of any further therapy, unless it is a targeted approach, is likely much smaller.
In my center, patients who progress on platinum chemotherapy or targeted agent, of course, are offered clinical trials. But I think we have to keep in mind that clinical trials are difficult sometimes to put patients in, and not everyone qualifies for a clinical trial. If you look at the second-line treatment landscape in lung cancer, currently, for advanced stage disease, it's pretty small. There's actually only 3 drugs approved second line when patients progress on chemotherapy, and they are erlotinib, pemetrexed, and docetaxel. So I think that we really, hopefully, will make gains in terms of new drugs that are available second line, and clearly the PD-1 and PD-L1 story, as it begins to be told, those drugs may fit in the second line. But until we have those drugs available or others, the only drugs we have are the ones that I spoke about. And for patients who progress on platinum pemetrexed and have received maintenance pemetrexed, or either progress on the induction regimen or progress after maintenance, I generally default for fit patients to docetaxel, but clearly erlotinib is another option. Now, there are controversies about whether erlotinib should be given to a patient's second line who does not harbor an EGFR mutation. But what I think we've seen in multiple studies is that there's no survival advantage or no survival difference between docetaxel and erlotinib in an unenriched group of patients second line. So I think both of those are options, and similar to the considerations for first line, I think we have to consider patient toxicity, patient tolerability. So patients who have received platinum pemetrexed with maintenance pemetrexed who have progressed, I talk to them about the role of another cytotoxic drug that may cause neuropathy and hair loss versus a pill, and the differences between those. I think that, again, most of the literature supports that those two are equal in their efficacy in terms of survival. Maybe not progression-free survival, but survival. I think there are also certain tools like Virostrat, which is a blood-based test that may help guide second-line decisions. For patients whose blood test is Virostrat good, we know they do as well with erlotinib compared to docetaxel. For those that are Virostrat poor, we generally would not offer erlotinib. And I'm hoping in the coming years that we will have more available drugs for our patients. But it's so important in the second line to truly consider patient preference. And patients who have really struggled with chemotherapy first line may not be able to tolerate docetaxel, may not be able to tolerate gemcitabine, another drug, and you may have to talk to them about either being on a clinical trial or being offered a pill. That's the beautiful thing about these PD-1, PD-L1 drugs, is that yes, their efficacy is something that we've never seen before and has generated so much excitement, but it's the tolerability that really is starting to make these drugs very exciting. So I think similar to the first line setting, you gotta talk about efficacy, but you must talk about tolerability. I mean, goals of care, again, are palliative, not curative. So we must deliver therapies that are tolerable and equally as efficacious as others.
Many patients that we see in clinic don't quite match the same patients that were placed on the clinical trials that we read about in journals. Many more patients that we see in our practice tend to be in poorer shape. They have worse performance status. They have comorbidities that preclude the application of the recipes that clinical trials had lined up for us. I think in the end, we need to individualize or personalize our therapies, even if it's chemotherapy, similar to how we personalize or individualize therapies for patients with actionable drivers in their cancers. In patients with compromised performance status, we sometimes feel that full-dose platinum-based therapy may be too much and that patient may not be able to handle such therapy. But in reality, I've personally seen that many patients with compromised performance status, particularly those whose performance status is compromised because of the cancer and not because of other comorbid conditions, they tend to benefit from chemotherapy that we would otherwise offer to somebody with better performance status. So in my own practice, patients with PS of 2 tend to receive platinum-based chemotherapy with carboplatin as the platinum backbone, and I try to give 4 cycles of therapy to those patients, knowing that I need to be more attentive, even more attentive to that patient's side effect profile and manage their experience through the chemotherapy treatment, because in those patients, the toxicities of chemotherapy can be and will be more pronounced. So you have to be more attentive to patients with PS2. However, those patients are not precluded from receiving platinum-based chemotherapy, as available data seems to suggest that those patients also have a benefit in terms of response rate, progression-free survival, and overall survival from platinum-based therapy.
In this era of immune checkpoint inhibitors, We are seeing patients who've had refractory cancer, who've had multiple lines of chemotherapy, have really exciting and durable responses to these classes of drugs. Finding out which patients will benefit most with this class of drugs is certainly an area of active investigation. There are a lot of drugs in this space currently, but we may have a lot of good options for patients that we might not have treated several years ago. And this is analogous to finding out a patient has an EGFR mutation. It might have been an elderly patient with a lot of symptoms from their cancer. You can really turn their lives around with treatment with oral chemotherapy. And I think if we see some of these nice responses, and we continue to see some of these nice responses, hopefully we'll be in a similar position with the checkpoint inhibitors.